Hello everyone, welcome to this tutorial on leukemia. This is part 2 where I will be covering in depth about the diagnosis and management of acute leukemias. If you haven't already seen my part 1 video on leukemia overview, I recommend you do so you can get a thorough understanding.
Disclaimer, this video is aimed at medical students for learning and revision purposes only. For medical advice, seek a qualified clinician. Every effort has been made for the information to be as accurate as possible and in line with the UKMLA specification. However, if you find any errors, please notify in the comments. Note, this video is not sponsored or accredited by the UKMLA, MSc or GMC. Hope you find the tutorials useful. Best wishes.
Remember the two types of leukemia I covered in part 1. Acute leukemias consist of lymphoblastic and myeloid leukemia. Let's start with acute myeloid leukemia. Acute myeloid leukemia, or AML for short, occurs due to clonal expansion of myeloid blasts in the bone marrow due to a mutation stopping its differentiation, as seen in this image. Most causes of AML are idiopathic, i.e. unknown, and secondary causes include myelodysplastic syndrome, chronic myeloid leukemia, and radiation. AML tends to affect the elderly and men more than women. Acute promyelocytic leukemia, or APML, is a subtype of acute myeloid leukemia defined by the translocation of chromosome 15 and 17, creating the PML-RARA fusion gene. This halts the promyelocyte differentiation. Patients typically present with severe bleeding, including CNS bleeds, due to enhanced fibrinolysis and disseminated intravascular coagulation. Unlike AML, APML typically affects young adults aged between 20 and 40, and it has the best prognosis of all AML subtypes. So I included this diagram to essentially tell the difference between what AML and APML is. AML and APML are determined by where the mutation occurs and what differentiation is blocked. As seen in this diagram, the mutation blocks differentiation at a later stage in acute promyelocytic leukemia. Both these mutations cause uncontrolled proliferation, causing blast cells to accumulate and occupy more space in the bone marrow, meaning less space is available for normal, mature cells. The signs of AML are due to the respected cytopenias and organ infiltration. For example, ecchymosis and petechiae can occur due to thrombocytopenia. Hepatosplenomegaly and swollen gums can occur from organ infiltration of leukemic cells, and also from extramedullary hematopoiesis because the bone marrow cannot sufficiently produce enough mature red cells. In order to diagnose AML, the first appropriate investigation to do is a full blood count where pancytopenia can be seen. This is defined as anemia, neutropenia, and thrombocytopenia. A peripheral blood smear is a useful investigation as they can identify our rods in both AML and APML. What further distinguishes APML is the hypergranular promyelocytes with bilobed nuclei, which is shown in this image here. A bone marrow biopsy is the gold standard to making the diagnosis. You can do a flow cytometry to identify the type of cell involved and also quantify the number of myeloblasts. Equally, this can also be done in the peripheral blood smear. For the UKMLA, you do not need to know the specific types of management as this is actually specialist driven. Generally speaking, chemotherapy is the main course of treatment for both AML and APML. A useful thing to remember is that APML has a very good prognosis if treated early, but the biggest risk of APML is the bleeding. Now let's move on to acute lymphoblastic leukemia. It's a rapid progressive cancer of the lymphoid precursor cells as shown in this image here. Is the commonest leukemia in children aged 2 to 5 years and is associated with Down syndrome, trisomy 21. There are two types of ALL. It can be T cell or B cell. B cell ALL is the more common subtype, often occurs in children, and the separate feature of a T cell acute lymphoblastic leukemia is the mediastinal mass because the thymus is involved, because this is where the T cells mature. Generally, B cell ALL has a good prognosis compared to T cell. There is an overlap in the signs of AML and ALL. However, lymphadenopathy is more common in ALL because of the involvement of lymphoid cells. Hepatosplenomegaly can be seen in ALL because of infiltration of the leukemic cells. The mediastinal mass is a specific feature of T-cell acute lymphoblastic leukemia. The mediastinal mass can obstruct the superior vena cava and cause respiratory distress. The involvement of the central nervous system is a common feature of acute lymphoblastic leukemia. Hence, patients can present with headache, seizures, vomiting, and cranial nerve palsies. A buzz tip to remember is that always consider ALL in a child with petechiae or unexplained bruising. The diagnosis of ALL is almost ditto for AML. You will do a full blood count, which is not the best in guiding what the diagnosis can be. However, a blood film is a standard investigation to do. And one would observe lymphoblasts, which have a high nuclear to cytoplasmic ratio. Diagnostic criteria for ALL is identifying lymphoblasts for more than 25% of the sample taken. A bone marrow biopsy again is needed to confirm the diagnosis, and again, flow cytometry can be done for immunophenotyping, i.e. which type of cells are involved. Hence, this can guide the management for the specialists. Poor prognostic factors of ALL is the presence of the Philadelphia chromosome and a high white cell count. So how do we manage ALL? Again, this is not needed for the UKMLA. However, it is good to know that the treatment for ALL is split into induction, consolidation, maintenance, and CNS prophylaxis. Most of the time, you have a multi-chemotherapy agents such as vincristine, prednisolone, daunorubicin, and L-asparaginase. Patients who have a relapse of ALL can benefit from CAR-T or allogenic stem cell transplantation. It is important to know about the complications of acute leukemias. One common presentation is tumor lysis syndrome. And the reason why this occurs is because there are many leukemic cells, and hence when patients undergo chemotherapy, a lot of these cells can die and release all massive cytokines, which can result in tumor lysis syndrome. Another complication is neutropenic sepsis. Because the bone marrow cannot produce mature blood cells, the lack of neutrophils predisposes people to infections, and hence people can develop neutropenic sepsis. Bleeding is another common feature of all types of acute leukemias, even although it is more common in APML, and this occurs due to the thrombocytopenia. Chronic fatigue is a common presenting complaint because of the chronic anemia that occurs with these leukemias. So this is a table that summarizes the differences between AML and ALL. This essentially provides a summary of what we went through in this presentation. I thank you for watching this video. I hope you found this useful. If you did, please make sure to like and subscribe, and I'll see you in the next one.